Thank you, Magnus. So this is our presentation. It was a proton pump inhibitor-induced dermal hypersensitivity reaction that was masquerading as an arthropod-bite reaction. So the abstract, and to summarize it, basically, we had PPIs are some of the most commonly used drugs used today to reduce gastric acid secretion. You may have seen them being used in the hospital. A lot of patients are on protonics when they're admitted. And studies suggest that an increase in adverse drug reactions caused by PPIs. And the true rate of hypersensitivity reactions to PPIs is unknown, despite frequent prescription. And the diagnosis of PPI-induced drug eruption can be challenging to diagnose and heavily relies on the history of the patient and clinical presentation. So we present a 73-year-old woman who presented with a resistant drug rash that was initially thought to be an arthropod-bite reaction based on histopathology. After extensive workup, pantoprazole was identified as the inducing factor, highlighting the importance of considering PPIs as the possible cause of drug eruption. The introduction, so PPIs are, once again, one of the most commonly used drugs for upper GI disorders, but no single drug has been identified as a major cause of PPI-induced skin reactions. Skin testing can be quite challenging just due to the multitude of maintenance drugs. And in this case, it was later discovered that pantoprazole was the cause of her rash. So we'll go through the case report to kind of detail the history of this patient. So we had a 73-year-old woman presented to the dermatology clinic with a diffusely pruritic erythematous and papular rash which began 4 days after she underwent a colonoscopy 2 weeks ago. Past medical history was notable for colon cancer in remission following resection and chemotherapy, hypothyroidism, asthma, depression, and isolated IgG hypogammaglobulinemia with specific antibody deficiency. She had no exposure to pets, and history of recent travel was negative. Physical exam was pretty much unremarkable, except for skin findings of multiple discrete erythematous, edematous, grouped papules with overlying excoriations diffusely present throughout the chest and extremities with no involvement of skin folds and web spaces. And you can kind of see that in figure 1A and 1B in the middle here, where she had just multiple diffusely spread out erythematous grouped papules overlying the chest and the extremities. She reported minimal relief from using camphor menthol lotion and hydroxyzine, and she had also tried prednisone with temporary improvement of symptoms. And at the time of her presentation, she was on azithromycin. Other medications that she was taking were albuterol or aripiprazole, azolastine, calcium, and then cholecalciferol, clobetasol, duloxetine, fluticasone, ivermectin, levothyroxine, nitroglycerin, pantoprazole, pantofixylane, propranolol, verapamil, cholecalciferol, and zolpidem. So you can see she had quite an extensive drug medication history, which kind of made it challenging to rule out what could be the cause of her rash, which kind of started spontaneously. So PPI-induced drug hypersensitivity reaction was favored. Differential at the time of presentation was urticarial dermatitis and bullous pemphigoid. She was advised to adhere to a strict sensitive skin regimen and was tried on triamcinolone, doxapen, and levocetirizine. Punch biopsy revealed a single erythematous papule, which was also obtained at the initial visit, which showed histologic changes consistent with an arthropod-bite reaction, revealing dense superficial to mid-dermal perivascular lymphoplasmacytic infiltrates with vaguely nodular and wedge-shaped formation. There were numerous eosinophils present and mixed within the dermal infiltrate. So that's why initial decontamination protocol with scabies and bedbug infestation was also favored and followed. But that led to no improvement in symptoms. 1 month later, after stopping the protonics, after she had an appointment with a neurologist, actually, she saw pretty remarkable improvement in her rash, and then she followed up after that with no new lesions developed, and the shave biopsy also revealed consistent changes from the past, and then resolved changes. So in summary, she returned to the clinic 1 month later to report that the rash had finally resolved on its own, and this happened after stopping the oral pantoprazole after the recommendation of a different physician. And then she was also counseled on switching to a different medication drug class within the PPI group, as patients are not likely to be sensitive to all of them. Discussion: PPIs are some of the most commonly used drugs for GI disorders. They have been associated with various skin reactions in the past, not necessarily pantoprazole, but others like omeprazole have been. Arthropod-bite reactions typically manifest as papular urticaria with eosinophilic spongiosis on histology. And the patient was, in this case, taking multiple medications, which made it very difficult to pinpoint the cause of the reaction to a specific medication. So in conclusion, clinicians should recognize cutaneous reactions to PPIs and include them in the differential diagnosis, especially in patients that are taking multiple medications for different comorbidities. And increased awareness of these reactions can also improve diagnosis, management, and patient outcomes. Thank you.
What wonderful. Are there any questions for him at this time? How long did this patient take PPI before she started noticing rashes? And then on top of that, typically on average, how often do these rashes occur for patients that take PPIs like this?
Yeah, that's a good question. So in this case, the patient was taking it for a few weeks. She was having primarily acid reflux, which is the reason why she started pantoprazole. But she didn't really notice the rash spontaneously right upon starting them. It was kind of developed over time, and this could just be the patient not noticing it right away because it was very diffusely spread out, and there were small pinpoint papules which are hard to notice sometimes, especially on the chest and back areas. But after a few weeks of taking it, that's when she started realizing it, but she never attributed it to pantoprazole.
All right, wonderful. Thank you so much. And